Corey. If you don't know who I am, I'm second year. I asked Dan Batsie to come down and talk about access deviation. He taught me paramedic class, does a fantastic job, does a bunch of education stuff. So I think it'll be really worthwhile. If you have any questions, obviously, go ahead and ask.
Very well. Hi, everybody.
Hi.
There's like a Frank Sinatra at the Sands microphone that I can use if you need me to, but I generally have a booming enough voice that, is everybody okay with that? All right.
Yeah.
Gives a little more homey feel kind of deal going on here. Okay, so thank you for inviting me and thank you for having me down here tonight. My name is Dan Batsie, and my principal job is I'm the education director for a group called Atlantic Partners EMS, and we run the paramedic program for Bangor and Waterville, and probably soon to come in Portland as well. So each semester I teach one class in the paramedic program, and cardiology is sort of one of my favorite hobbies as we've gone on. Now, I will admit this is a bit outside of my wheelhouse tonight because I don't, usually by this time I have a very good sense of where people are and the foundations that they've been given. So I'm going on some assumptions that you've had some foundational stuff and are probably smarter than the average bear kind of stuff going on. But please, if we have to slow down, just let me know. Or on the other hand, if we have to speed up, that's okay too. What I'm going to do tonight is sort of just this is a lesson that I do usually after the first time we talk about access in the paramedic class, and everyone there realizes that I'm speaking Latin and they have no idea what I'm talking about. So this is sort of like the second blush into access, and it's designed to break it down a little bit more simply so that people can kind of begin to swish it around in their brain a little bit. I can firmly remember my first day in access in paramedic class and having absolutely, you might as well be talking about particle physics because I had absolutely no idea what they were talking about. And it's a tough concept. It's tough because it doesn't have like a practical application. Like you can't somehow, touch it and feel it and digest it. You have to kind of just lay back and let it sort of wash over you a little bit. But I have found that there are some practical analogies to use with this that are kind of helpful, and that sort of once you get it, it's really simple. And for the most part, I mean, unless you're going to be like an electrophysiologist, the use of this is fairly straightforward and fairly simple, and the precision is less important than the overall broad concept. So that's the preamble that I usually bring to this, and here we go. All right, so a quick review. You've had the EKG basics before, right? So you know that for the most part in a bipolar lead, we're looking from one point to another, right? And the simplified application of that is like two guys with binoculars looking at one another from one point to another, right? Now, of course, we're measuring the changes in electrical activity going on between those things, but it's still a vector of sight. It's a line of sight that we're looking at. Now, a bipolar lead is really useful, and it's very useful for a lot of things, but in particular, it's useful for seeing things that are within that line of sight. So if you put, for example, if I'm looking towards another guy with binoculars, I put something in the middle here, it's easy for me to see it. And I go, whoa, of course, there's a lion there, and it makes it really straightforward. The hard part with a bipolar lead is you're only looking in one line of sight. So if something is happening over here, we don't see it very well, right? It's a limited range upon which. Now that's the reason why we have 12 and 19 lead EKGs and 30 lead EKGs in the EP lab and all that kind of stuff, because we need to see all those different things, but that's where it is. So things that are outside that line of sight, not so good. Okay. Now, Dr. Einthoven, back in the 1800s, composed Einthoven's triangle and created leads 1, 2, and 3, right? And those were three separate viewpoints looking essentially through the heart, if you will, but three different lines of sight. And he created those by putting his arms and legs in buckets of saline and, swishing them out and putting the other leg in. And he created all those different leads that we are sort of very fond of today and know a lot about. Now, this is a compass. Anybody here taken land navigation or sailing or something like that? Okay, so when the compass was invented, they said we go in different directions, and we can use those directions to navigate. We can say we're going to go east, we're going to go north, we're going to go south. And in fact, when the compass was invented, some guy somewhere, and I don't even know who it was, said, let's assign some numbers to these directions. Let's assign the numbers to the cardinal directions, and we'll make north 0, and east 90, and south 180, and so on and so on and so on. Now these are arbitrary numbers, right? Some guy just said, let's do this, right? Okay, so that's an important principle. Now, here's the other thing that I want you to think about with regard to the compass. I could go out in the street out here and wander around in any particular direction. And I can do that whether you're measuring where I'm going or not, right? So the fact that I'm out wandering around campus and happen to be walking in the eastward direction means nothing unless somebody goes, he's moving east, right? So this is just a part of learning navigation, but the reality is, so for example, if I dumped you into the middle of the forest and just gave you a compass, you'd never get out alive, right? Because you have to have some orientation of the things around you, right? If heading east is where you need to go to get out of the forest, that's great, but you got to know you got to head east, right? So you got to have a map, and you got to sort of assign those directions to things that are meaningful. Fair enough? I know that's kind of a very vague thing, but it'll get more meaningful here in a minute. Okay. This is the compass we use for electrophysiology, right? Have we talked about this before? Okay, so we have, all right. So the hexagonal reference system is the compass that we use to determine axis. And all it is, right, so think of it like the compass that I just showed you, right? A long time ago, some old cardiologist said, let's assign some directions to the vectors that we look in the heart. Right? So he said, all right, let's draw out lead 1, let's draw out lead 2, let's draw out AVR, AVF, AVL, right? And let's assign some numbers to it. Now, unfortunately, you can't take the compass analogy too far because it's not the same numbers, right? So north is not 0 in this one, right? And we always, the saying that we have in paramedic class is, why? Because cardiologists hate you. Right? And they've just decided to make this as challenging and difficult as possible because there's no way this makes any sense in any way. You just got to learn it, right? But what they did was they put all those vectors down and said, let's assign some numbers to them. So lead 1 became the cardinal direction, and that line of sight is they've assigned 0 degrees, right? And then 60, 90, 120, and then they become negative 30, and so on. Everybody follow me? And again, don't let the numbers blow your head away because they're really not all that significant, and I'll explain why that is. So it just sort of have to let it wash over you for a second. Okay. So what we want to be able to do then is use this to navigate how energy moves through the heart, right? But remember, this by itself means nothing, right? All this is a compass. All this is a map, if you will. Right? Without having some orientation of the directions that are really happening, this is nothing. So, for example, right now, in all of your hearts, energy is moving typically from the top right to the bottom left, right? And it's not really two-dimensional, but we're going to pretend it is just for now, okay? It's happening now, and it's happening regardless of whether we're measuring it, right? So it's going on right now. I don't know what direction it's going, but it's going. Right? So what we're going to do is use axis and use the hexagonal reference system to be able to say, okay, now that I have this tool, let's figure out what direction energy is actually moving through your heart. Because there's some use to that, right? I mean, if a person has a big bundle branch block, that is going to change the sum of the energy moving through. It's going to shift it in one direction. A person has a big right-sided MI. It's going to move it in a different direction. There's a lot of reasons why that energy might move, and it's valuable for us to say, oh, well, here it is. Now, the other value of this is that the very principle about why things are upright or why things are negative is based upon how energy is moving towards the pole that you're looking at it. Right? How energy is moving towards a positive pole. And we'll get into that a little bit too. So to me, axis is not so much a skill, so especially for paramedics, axis is not so much a skill that is, we have to know how to measure axis because it's a life or death emergency. It's not, but it's the principle that allows us to say, well, this P wave is upright and this P wave is negative. Now I understand why that is. More on that in a minute. Okay. So, what we do, what I'd like us to do, and what I'd like us to think about, I forgot to bring it tonight, I have a little clear plastic sheet that I've drawn the hexagonal reference system on, right? And what I do is I say, okay, now we're going to take this compass, this hexagonal reference system, and overlay it on somebody's chest. Because that's really all we're doing, right? Because the energy's moving in that heart, whether we're measuring it or not. Now we're simply going to place this overlay on the person's chest, and it's going to allow us to help understand how that energy is moving a little bit differently, okay? Now, as we mentioned before, there's some cardinal directions. So when Dr. Einthoven invented lead 1, and he placed the negative lead on the right arm and the positive lead on the left arm, right? And he measured the energy, and he looked from that right arm to the left arm, right? He created lead 1. And that is that cardinal direction. That's 0 on the hexagonal reference system. It's the horizontal line that crosses. Follow me so far? Okay. So that's sort of what if you were to draw one line on the hexagonal reference system, that would be your first one right there, right? 0, that's the direction. And again, doesn't say anything about what's actually happening in the heart. All we're doing is assigning a direction. Okay. All right. So again, if you looked at the hexagonal reference system that I showed you before, that's what lead 1 would look like. Okay? All right. Lead 2, they assign 60 degrees. And that's from the negative pole on the right arm to the positive pole on the left leg. Okay? So that forms another line on the hexagonal reference system. And if you were to label it on the one that we've seen before, it would look like that. Okay? All right. Lead 3, positive 120, left arm to left leg. Right, creates that third side of Einthoven's triangle, right down like that. And then we use a mathematical, it's actually a logarithmic equation to then figure out, if you know what lead 1 and 2 are, you can figure out what AVF is. And if you know what lead 1 and lead 3 is, you can figure out what AVL is. So by mathematics, we can also then assign these other leads, AVL, AVF, and AVR, right? Augmented voltage right, augmented voltage left, and augmented voltage foot. Okay, so they're also going to be labeled on the hexagonal reference system. AVF is straight down, right? Positive 90. AVR, negative 150, back up to the left arm, right? And again, if you sort of, this is not a wholly accurate statement, but if you sort of think about almost like starting in the center of the heart, looking out to the positive electrode on the right arm, right? Starting in the center of the heart, looking down to the positive electrode on the foot. That's the way, it's not, again, it's a mathematical equation, it's not an actual lead, but it's sort of a helpful way to think about it, okay? And then AVR, we talked about that, and then AVL, negative 30, going up in that direction. Okay. Everybody, basic stuff, everybody tracking so far? Okay, now, we know that when you move energy towards a pole, we can graph it on graph paper, which is basically the basic principle of electrocardiology, right? We graph changes in electricity over time, and when we move energy towards a pole, it's going to have both time and also amplitude, right? It's going to have size. And we're going to be able to use that to help us determine where that energy is moving using the hexagonal reference system. Now, this is really important. We know that when energy moves towards a positive pole, it gives us a positive deflection on the EKG paper. Everybody cool with that? We also know the closer it is to directly towards it, the more upright it's going to be. So let me say it this way. I'm standing on the main turnpike. I'm in the center lane, and I've got my binoculars out, right? The truck is coming to me, it's coming directly at me, right? What's it going to look like right before it hits me? Really big, right? Really, really big, and it's going to get bigger. The closer it gets to me, the bigger it's going to be. Until it almost hits me, it's going to fill everything I see, right? It's going to be the biggest viewpoint that I can possibly have because it's coming directly at me. Okay, now I'm standing on the main turnpike, I'm looking that way, but the truck is coming from over here. What am I going to see? Very little, right? I mean, maybe nothing at all, or maybe I just sort of catch a glimpse of it. So it's going to be relatively small compared to the big truck that's coming directly at me. And then what we want to think about is everything sort of within this is going to be is going to vary depending upon how close it is coming towards me, right? So the closer it is, the bigger it is, and the further away from my line of sight it gets, the smaller it gets. Okay, everybody tracking? Okay, now it goes by me, and I turn around real quick and look at it. The further it gets away from me, what's it going to look like? Smaller and smaller and smaller, right? So if it's traveling in the opposite direction, it's going to create a negative deflection, right? And again, everything from the point in which it's not traveling toward me, but actually now traveling away from me, it's going to be getting smaller and therefore negative. All right, now that will make more sense. So the rule of electrical flow is saying that the energy that moves towards a positive pole creates a positive deflection. Energy moving away from a positive pole creates a negative deflection, right? Energy traveling perpendicular to that, right, to that positive pole creates either no deflection at all or what we refer to as a biphasic deflection. It is as positive as it is negative, right? And that's the principle by which we're going to use to measure all the things that we're going to do. Okay, so we talked about all that. Okay, so when we talk about that, we're going to then take the work of Dr. Einthoven, and we're going to look at the leads that Dr. Einthoven taught us, leads 1, 2, and 3, and then we can add in AVF, AVR, and AVL, and take a look at what those leads are doing and figure out just exactly what's happening in that heart. So, let's see where you're at so far. In an average heart, normal heart, the general sum total of the energy that moves through it generally goes from top right to bottom left. Is that everybody happy enough with that? Does that make sense? So you're starting up in the SA node. You're and I know that we're depolarizing in a 360-degree circle in a lot of directions, but generally speaking, we're going downward, right? So what lead, if I looked at leads 1, 2, 3, AVF, AVR, and AVL, what lead would most similarly replicate energy moving towards in the real heart? So which positive pole would be almost directly looking at the energy coming through it? Okay, so AVL's up here, right? So if I look from the center of my heart, it goes this way, right? And the energy's going this way. So is that going to be the most positive one? You're saying lead 2. Right? Does everybody understand that? So if energy is moving this way, right, lead 2 looks from here to here. Right? So it's right down here. It's going, hey, what's coming? Whoa, everything is coming. Right? AVL's kind of going, I think something's happening over there, but I'm not really sure. Do you understand what I mean? Okay, so that's going to be an important thing to think about. So if we were to look at this, and we said, let's hook this guy up to EKG, and we're going to see what's going on in his heart, because, again, remember that his energy is moving whether we're looking or not, right? And all we're going to do is take that hexagonal reference system, put it over his chest, and say, let's look at some of these leads and see where energy is moving through his heart. So what I should see is leads with different looking amplitudes. Some are positive, some are negative, and the reason for that is because we're placing different positive poles close to and sometimes away from energy that's moving towards it. Let me reverse the question. So if 2 is the one that's most positive in a normal heart, which one should predominantly be most negative? Einthoven's triangle, think about it. Say it.
AVR?
AVR, right? Why? Explain.
Somewhere up here.
Yeah, because here's AVR. We're looking from this way to that way. And in a normal heart, energy's going this way. So AVR's going, hey, look at it getting smaller, I can't see it anymore. Right? It's going in the opposite direction, generally speaking, in a normal heart. Everybody follow that logic? Yes, ma'am.
Is the point of having AVR just to be in opposition to lead 2? Why did they create AVR, AVL, and AVF?
Well, I mean, I think there's a great many functions for it. You know, and not only does it help us determine axis, but it can also look at things that are happening in that area of the heart too. I don't know that I have a great answer in terms of why leads were created. I think it certainly does serve as a very good counterpoint to the viewpoint for lead 2, right? Just as AVL serves as a counterpoint for the view of lead 3, right? But to say that it was designed specifically with that in mind, I don't know that I can say that. All right, other questions? Okay. So, here's our normal heart, right? Again, this is your heart right now. We're not even looking at it. We're just knowing that it happens. And by the way, again, remembering that energy is displacing in all different directions all the time, right? Because it's not on a straight line. You know, we've taught you for years the mumbo jumbo about the SA node and the AB junction, like it's a big piece of string that goes through your heart. And of course it's not, right? There's literally thousands of independent, small, little pacemaker cells that make up that. And remember, when those pacemaker cells fire, they go in this direction and that direction and this direction, and it spreads. I always say that energy spreads in the heart like the wave at a football game, right? Where one guy stands up and then everybody around him goes, hey, right? But it doesn't spread in just one like bleacher row. It spreads up and down, and that's why when we look at it, it's going in sort of all these different directions, right? So the same thing's happening in the heart, right? It's spreading up and down in other directions, but when we add up all the vectors, when we add up all the directions that it's going, the sum total of all those directions is kind of like this way. Fair enough? And just like when we add up all the directions in the wave, the sum total is going that way around, right? So I think that's kind of a helpful thing. So here's our heart going that way. So then we're going to say, all right, let's figure out where the energy is going through. So let's hook them up to EKGs. Let's put that positive pole on his left leg. Let's put that negative pole on his right arm. Let's configure lead 1, lead 2, lead 3. And then we're going to examine what those leads look like to determine which one of those leads represents where that energy is actually moving, right? And we're going to do that by looking at amplitude. So there's my lead 2, for example. There's my guys looking at that. And now energy is moving towards this guy, right? So if this was happening, what should lead 2 look like? Should it be negative? Why not? This is a very important point. Why should lead 2 not be negative in this case? Right, because the energy in this heart is moving towards where I've placed that positive pole. Right? What should AVR look like? It should be negative, right? Because it's over here, and in this particular case, energy is moving in this direction. Okay? Now, let's see how much you're paying attention. What should lead 1 look like? Okay, it should be positive. Why? Because it's still kind of going towards there, that way. What should it look like in comparison to lead 2? Smaller, right, a little bit smaller, but still positive. Does everybody understand why? Because that energy is still moving in its general direction. It's not going away from it, right? When would it become negative? What circumstance would it be negative?
It's going towards the right.
Yeah, if the energy somehow got to a place where it was moving away from it, right? So as long as it's moving in that general direction, any of those directions, it's going to be positive. The moment it begins to move away from it, any of those directions, it will be negative. Fair enough? Okay, I keep asking you that. I don't mean to be repetitive, but I do like to check in because I'm trying to figure out where you guys are at. Okay, so generally speaking then, a normal heart, a normal axis should show us something that looks like this. A really positive lead 2, a pretty positive lead 3. Why would lead 3 be positive in this? Yeah, because it's still going towards that lead, right? Remember that the positive pole of lead 3 is still the left leg, right? So it's still moving in that direction, just not moving as precisely parallel as lead 2 is. Okay? And then, as we mentioned, lead 1 would be positive, but it would be much less positive than 2 and probably less positive than 3. Okay. All right. So we talked about that. Right? So what lead is this? That's lead 1, right? So I've configured, I'm looking from the negative pole on my right arm to the positive pole on my left arm. And again, you see it's still moving towards it. It's just not moving as parallel towards it as lead 2, right? Or for that matter, lead 3. Same thing here. Again, it's still moving towards it, but just not quite there. Okay. Now, we can further take the hexagonal references. So the most functional use of the hexagonal reference system is to say, what quadrant of the heart is that energy moving in, right? Especially for paramedics. Our day-to-day stuff is not to say you're moving at a positive 90 axis, because we don't care about that stuff, right? We just want to pick up the big changes. If you work in the electrophysiology lab, you do need to know you're 91. Now, the good news is your monitor, you push the button, it goes 91, QRS axis 91. So you don't have to worry about that too much. But it's sort of functional to be able to say we should have a sense of how energy moves through there, because there's normal versus abnormal, right? And we know that energy that sort of moves towards this direction in any of these sort of vectors right here would be considered normal, right? It should be going, generally speaking, from the top right to the bottom left, right? And there's some variability in there for the big ladies with pregnant bellies and big fat beer belly guys and stuff like that, right? There's some variation in terms of how the heart seats, but generally speaking, it goes in this direction. It ends up in those vectors, okay? Now, we can change things, and we'll talk about how it changes. We might have energy that sort of moves more towards the left side. We call that a left axis deviation. We might have it move more towards the right side, so a right axis deviation, right? We might even have an extreme right axis deviation. That would mean that the energy predominantly is moving from the bottom to the top. Can anybody think of a condition where that would happen?
Can VTAC do it?
Yeah, ventricular rhythms sometimes will do it. Now, there's other things, right? But the first thing that we think of, the paramedics think of when they see extreme right axis deviation is, why is the energy going this way? Right? So if that impulse is beginning way down in the ventricles, like ventricular tachycardia, and then somehow depolarizing the heart in a backward fashion, we go, wait a minute, that's possibly dangerous, right? Now again, I want you to understand that not every extreme right axis deviation is going to be ventricular, right? And not every ventricular rhythm has an extreme right axis deviation. But it's sort of a good clue, and in fact, when we're thinking about differentiating the very, sometimes very complicated, is it VTAC or is it a sinus rhythm with an aberrant QRS complex? So let me give you an example. What's your name? Mitch. Mitch has AFib all the time, right? And he's just, he's been years of crystal meth use have created a very brittle heart. He's got AFib, right? And he's also got a right bundle branch block because he had a heart attack 2 years ago, right? So if you were to put an EKG lead on him, you would see a big wide QRS complex, right? Okay, so he's got AFib and he's got a big wide QRS complex on a good day. So now he develops a chest cold and it's really taxing his system, right? It's really making him feel sick. He's a little dehydrated, so he's tachycardic. He's just generally feeling bad. But he's got this big wide QRS complex every day. So we hook him up to the EKG lead and his heart rate is 130. And when I look at the leads, I see no P waves, because he's got AFib, right? And I see big wide QRS complexes. And I go, holy Moses, he's in VTAC, if I don't do the steps like I'm supposed to. And it's very easy, and in fact happens all the time, where he gets misdiagnosed as a ventricular rhythm, and in worst case, treated as a ventricular rhythm. He doesn't need to be cardioverted, right? That's going to make him worse. Right? And he doesn't need me to slow his rate down because he needs that rate to compensate for whatever challenge he has. But that's a very common mistake. So one of the things we can do is say things like, well, what's his axis? Right? If it's extreme right axis deviation, it makes us go, well, maybe this is ventricular, right? And there's a lot more to it. There's 10 other steps that we should be looking at. But that's one of the things that we can use axis for beyond just sort of the academic studying of what number it is. Does that make sense? All right. So let's look at this EKG lead. So what do you notice about this? Let's just talk about this really quick. So if I look at leads 1, 2, 3, AVF, AVR, and AVL, what can you tell me about those leads? So for the purposes of axis determination, we're going to skip V1 through V6. Fair enough? Now again, when we get to the electrophysiology lab, it's a little bit different, and there's more to it. But for the purposes of basic, simple axis deviation, we should be looking at the bipolar leads only and the augmented leads. All right, so tell me about leads 1, 2, and 3 in ABF, ABL. What do you notice about them? 2 is really tall, okay? So what should that make you think? If 2 is your tallest lead, what would that, generally speaking, tell us about energy moving through the heart? Okay, so generally speaking, we would assume, based upon looking at this, that energy is moving from top right to bottom left. Okay, now let's confirm that. We don't want to cite single sources. We're like the Washington Post here. We want multiple sources confirming, right? So how do we confirm that? So I'm sorry, what's your name? Chris. Chris said lead 2 is most positive, and therefore he proposes a hypothesis that energy is moving parallel to lead 2. All right, so now using the scientific method, as you're all scientists now, let's confirm our hypothesis. Let's test our hypothesis. So we'll need to look at some other leads now. Okay, so if lead 2 was the actual axis of energy, what should the other leads look like? And don't look at this, just think about it in your head. If lead 2, if the energy was actually moving on an axis parallel to lead 2, go ahead.
1 and 3 should both be positive.
1 and 3 should both be positive. Which one should be taller?
3?
Right. Does everybody understand that? So if that energy is moving towards lead 2, we should see 3 being very positive, and we should see 1 being positive, although 1 will be the least positive of the 3. Okay? Now, without looking at this, what should AVR look like?
It's super negative.
It should be negative. Does everybody understand that? Because if the energy is moving from top right to bottom left, AVR is here, what we should see is a negative AVR. Okay? How about AVL? What's that mean? You're right, but what does it mean?
Maybe a little positive, maybe a little negative.
Okay, so it might be a little positive, might be a little negative. To use the language of cardiology, it would probably be biphasic, right? It would be almost equally positive and equally negative. All right, so there's our hypothesis. Now let's actually test it. So we turn around and we look at the thing and we go, all right, lead 2 is positive, lead 3 is pretty positive, right? Lead 1 is pretty positive. That confirms his hypothesis. AVR is negative. AVL is, it's a little negative, so that may mean we have to adjust our exactly where this is going, but it still confirms what we've been thinking. Does everybody see how that works? Okay, now, Corey Cole, as a paramedic student, years ago, created this, the wheel of axis. And the wheel of axis helps us sort of conceptualize this, and it's been a wonderful tool. Corey, thank you very much. We now have 2 wheels of axis for both our paramedic programs, and when they break, I'm going to make 3 more. No, Corey's going to make 3 more, but anyway, it really is helpful. So here's what she did. So this is this arrow right here is is what we hypothesize to be the energy. Right? And then what we've done is just simply attach perpendicular lines to it. And the perpendicular lines say, as long as energy is moving within this half of the circle, what should the leads look like? Positive, right? And if energy moves away from this, beyond the perpendicular line, beyond 90 degrees to that, what should it look like? Negative. Okay, so let's look at this EKG lead we have right here. So when I'm determining axis, I think the easiest thing to do is look at the tallest lead first, right? And by the way, you could also go backwards and look at the most negative lead, right? Either way, it works the same way. So if we said, Mitch said before that lead 2 is most positive. So okay, here we go. Let's set our cursor then on lead 2. Okay, so lead 3 should be positive, right? Because it's within our 90 degrees perpendicular to where that is, right? We should see AVL be positive, also 90 degrees perpendicular. We can see AVR is negative because it's outside that circle, right? AVF would be positive because it's in here. Okay, now, in this case, what does AVL look like?
Slightly
Slightly negative. So how would that change where we have to put this cursor? Rotate it where? We got to rotate it clockwise, right? Because what this indicates is that AVL is outside of the perpendicular circle. Does everybody see where I'm going with that? Right? So I have to adjust it down a little bit here. Now, is it consistent? So if this is the case, let's just hypothesize for a moment that it's equidistant between 2 and AVF. Right? What should AVF look like compared to lead 2? Pretty similar, right? Pretty similar. Fair enough? We'll come back and talk about this in a little bit more. So this is a really useful concept. And again, I don't want you to be carrying around, wooden charts or things like that to do this, but I think thinking about this in terms of semicircles, right? Everything on the semicircle that's in front of that energy is going to be positive. Everything in the other hemisphere is going to be negative. And we can adjust as we go on a little bit. Okay. So, think of energy as a little tiny fish swimming down the stream, right? In our heart, we pass that depolarization, generally speaking, from the SA node down to the Purkinje fibers of the ventricles, and normally that little fishy swims unobstructed and has a little happy voyage down to the Purkinje fibers. Okay, and that's what happens in almost all heartbeats and normal depolarizations of the cardiac tissue. That's sort of what's supposed to happen, right? And because that has sort of a predictable direction of travel, we can say so if I took a compass out, like not the hexagonal reference system, right? If I'm standing on top of the stream, right, and I go, hey, look at that trout, he's swimming in that direction. I could take my compass out and go, oh, he's swimming at 90 degrees vector, right, with my compass. And I have that because my compass has little numbers around it. And I go, okay, so I visualize that there he goes, right? I can measure that, and that's how I would measure it if I was, a biologist charting trout travel in streams or whatever, okay? But unfortunately, sometimes stuff blocks travel, right? And if the little fishy had to swim down around a rock, it's going to change the direction of travel, right? So he goes all the way down, he hits the rock. Now he's got to change his direction of travel as he goes past the rock. Now remember, when I take my compass out and I say, what direction did fishy travel? I've got to add up both of those vectors to come out with the overall vector, right? So I have to take into account this vector, but I also have to add this angle here too. So what it's going to do when I add them totally up is it's going to make that angle a little bit different than the straight fishy angle, right? And in fact, it's going to deviate his angle of travel, right? And the same thing will happen in the heart. If the energy is obstructed and has to travel in a different direction, it's going to change the axis of depolarization because I have to add up all the different angles that have gone on there, and it's going to make that angle go either one way or the other beyond what normal is. Okay. So those are the angles that I've got to add up. And in this particular case, if I added them both up, it's going to change it. Now, he didn't really travel directly across that way, but this is the sum of the two angles that he traveled, right? So in other words, when I have a left axis deviation, it doesn't always mean that energy is going this way, right? It doesn't start in the bottom right and necessarily go to the top left. But if it goes this way and a hell of a lot of it goes that way, right? I'm now going to add those two up and I might shift my axis a little bit this way. Okay. So we can talk about things like this in the heart, right? When we add up angles of depolarization, when the sum of them is different, we can say they have an axis deviation. They have a change in the way that energy normally flows through the heart. And we can say there's a left axis deviation. We can say there's a right axis deviation. We can even say there's an extreme right axis deviation and measure those sorts of things. And that's where we use those quadrants for. And again, if you're in the EP lab, you're going to be much more precise because you want to know exactly where that aberrancy is coming from, and you can figure that out. But for the most part, this is the functional usage of this. All right, so let's take a look at this EKG. Who wants to help me out now? We're going to use back to Corey's chart. So if I wanted to determine the axis of this EKG, of this patient, how would I start? Where would I start? We said we want to start with what? Either the biggest or the most negative. So in this case, what's the biggest lead? Lead 3? Yeah, I would say so. Now, lead 3 is mostly negative. Does everybody agree with that? All right. So if lead 3 is mostly negative, we're going to go like this, right? Because lead 3's positive pole is down here. So my hypothesis then becomes that energy is moving this way. Does everybody see how we got there? Okay. Now, prove your hypothesis. If this was true, don't look at this for a second, look at this. If this is true, tell me about the other leads. If this is true, what lead would be most negative? I'm sorry, most positive. Think about it. AVL, right? Here's AVL. And again, if you're thinking about this sort of being in the center of my chest, there's AVL. Does everybody see how we've arrived at that? Okay. So, all right. So if we think AVL is going to be most positive, tell me about lead 2 in this equation. What would it look like? It would be a little bit negative, but remember, it's right next to that parallel line, or the perpendicular line. So tell me what else is going to be. It's going to be negative, but what else? How else is it going to look? Probably a little bit biphasic, okay? How about AVR? Pretty biphasic as well, right? Maybe a little bit negative if this is what holds up. How about leads 2 and 3, or 2 and AVF? What will they look like? So here's AVF. Energy's moving this way. What's it going to look like? It's going to be negative, right? Same thing with lead 2, right? Maybe a little bit of biphasicness to it. All right, so let's look at our hypothesis. So we said 3 is most negative. 2 is pretty biphasic. Does everybody agree with that? So how would that have to shift us a little bit? Right, 2's got to be kind of more like this, right? If 2 is biphasic, it's got to be almost perpendicular to the line of travel, okay? It would then mean that AVR would be what? Be negative. Well, we don't have AVR in this one, but you get the idea. Everybody follow how this works? Okay. So tell me about the travel of energy through this person's heart. Is it normal? Okay. So it's probably shifted a little bit left. Does everybody agree with that? Now, it is on the borderline, right? And we know that in a lot of people, there's such a thing as a physiologic left axis deviation, which means you got a big beer belly, which kind of displaces your heart a little bit, or you're pregnant or something like that. And that may be normal, right? It may be normal. Or it could be caused by something else, and we'll talk a little bit about what that's caused in a minute. Okay. So, a lot of things that cause left axis deviation. Right? A lot of things. And by the way, not everything is necessarily bad. And we refer to that as a physiologic left axis deviation. All right, how about this guy? Let's do another one real quick. Who else wants to help me out? How do we start? Somebody help me. Biggest one? So what's the biggest one? Okay, or, 3 is probably the biggest. But we just used 3, so let's use a different one. What's that? Okay, lead 2. Okay, how about AVL? That's the one that jumps out at me. Let's just use AVL. And the reason I'm doing this is I just want to show you the opposite of what we just did. So I'm choosing AVL because it's the most positive lead. Everybody follow me? All right. So here's AVL. I'm going to hypothesis that it's here. Now don't look at this. Think about this for a second. Tell me what lead 3 looks like.
Negative.
Negative, right? Because if my hypothesis is correct, energy is moving this way, the positive pole for lead 3 is down here. Right? Tell me about AVF. Negative. Okay, good. Tell me about AVR. Negative. Okay. Tell me about lead 1. Positive. Okay. Now, let's confirm it. So AVL, I look at one. One's pretty biphasic. How does that change my thinking? Oh, I'm sorry. One's not biphasic. I'm looking at AVR. AVR is biphasic. Sort of. Yeah, pretty much. Right? So maybe if AVR is biphasic, it's probably going to shift a little bit this way. Everybody follow how this works? Okay. It's not complicated, and it's mostly just about getting your head around thinking about those semicircles. All right, so in this particular case, we could hypothesize that energy is moving through this heart in this direction, right? And what would we refer to this as? Yeah, that's a left axis deviation. That's a left axis deviation, okay? Now, lots of causes for a left axis deviation. Again, sometimes pathologic, sometimes not pathologic. You know, the big stuff that happens is like an anterior fascicular block. So do we know what fascicular blocks are yet?
Not yet.
Okay, so not to get into this, right? But we know that AV junction, interneural pathway, bundled His, and then it splits. So you have the right bundle, and then you have the left bundle, which has 2, sometimes 3 fascicles, right?
That's the part we don't know yet.
Okay, so the left bundle splits, and because the left ventricle is such a big honking pile of muscle, it needs a couple different pathways. So 2, sometimes 3 pathways. Now, if we block one of those pathways, energy's got to change how it goes through, right? So let's just say that it looks like this, right? Going through the left ventricle. If I block this one, or actually better yet, if I block this one, energy comes down these guys, but remember, it hasn't gone through here yet. So where does the energy go? Fires up that way. And remember, left ventricle is big. So a big pile of energy has just gone, not as it normally would this way, but gone this way, right? So all of a sudden we're adding up all those vectors, all those angles, and saying, wait a minute, it's going this way. Fair enough?
Because the charge propagation through the muscle is slower, so it
That's right, exactly right. And also, because you have so much mass. There's just a huge amount of mass to depolarize. And as you know, energy is going to find non-depolarized tissue. When it finds non-depolarized tissue, it's going to go there, right? So it doesn't matter. The heart, the depolarization in the heart doesn't know what direction it's supposed to go. The only reason it goes this way is because those pacemaker cells depolarize at a lower threshold, right? So the basic principle is that they depolarize easier and faster. So that pulls it in that direction. But in the absence of those cells being ready, they're going to go, hey, I can go over here. Let's go this way, right? And it's going to find that non-depolarized tissue.
But Chris, I don't want you to confuse this with the left bundle branch block, because it's not that slow. This is still going to be pretty fast compared to an entire bundle branch block.
Oh yeah. So that's a little bit of a different concept. Yeah. There's a ton more here, right? We're scratching the surface here, because when you start putting, this is one element of blocks, right? And there's a lot more here. But it's not my intent tonight to get into too deep with, I mean, we could talk about it if you want to, but it's not my intent tonight to get into too deep the conduction blocks and things like that. But just so you know, a block is a prime cause of changes in flow of energy, right? One of the principal reasons why energy will flow in a different direction is because areas are blocked and they have to go around that area, and energy has to go around the area that's blocked, or go towards the area that's blocked from a different angle. Okay. Oh, and then other things as well, scar tissue, tissue that is no longer transferring energy like an MI state, and many other things as well. Okay, so how about this one? Let's just do a couple more and we'll sort of check in and see where everybody's at. Help me out. Somebody else do this that hasn't done it yet. How would I determine where the axis is of this guy's heart? Let's get a starting point. Somebody help me. I'll be here all night. I'll wait all night long for somebody to do this. You have no idea my patience. I'm like a patient on a monument. Fire away. Who's got it? What's positive? Which one's the most positive?
3.
Okay, 3. So you're hypothesizing then that the cursor should be placed somewhere down here? Okay. So all right, everybody agree with that? Okay. So if that's the case, what should AVL look like without looking at that? Think about this. Should be negative. Okay. How about lead 1? Should also be negative, right? 2 and 3? Positive. Okay. So now let's just do a quick check. Yep, 2 and 3 are positive. 1 is negative. Yep. So I think you hit it right on the head. All right. So what's going on in this guy's energy? Yeah, shifted to the right, right? He's got a right axis deviation in this particular case. So, okay. So his energy is moving this way. And again, a lot of causes for this. Many cases, bundle branch blocks, and not so much bifascicular blocks in this case, but a lot of situations of that. And again, remember, we're arriving at this conclusion by adding up all the different angles, right? So that sort of right axis deviation. The other big thing that we see that causes axis deviation is increases in mass, right? So a person that has hypertrophy, right? So when you increase the mass of a particular area of the heart, it's going to attract more energy. It's going to require more energy to depolarize. So if you think about a person, like a COPDer that has, massive right ventricular hypertrophy from pushing against that diseased state lung for so long, that may shift a lot more energy towards that right ventricle compared to a person that doesn't have that state. So lots of things, and again, there's a lot more to this, and I'll let you guys fill in the blanks as you sort of get further into electrophysiology, but nonetheless important. Okay, this one's a little trickier, right? And I'll tell you why. The reason it's trickier is because wide complex tachycardias are oftentimes hard to figure out whether they are negative or positive. In fact, they're really almost impossible to tell whether they're negative or positive. But sometimes you can, and sometimes you can kind of eyeball it. So in this particular case, let's just say that what we're seeing here is an R, so the first positive deflection being an R wave, and then this big, this big wide S wave, right? And if we determine that the baseline is here, we've called this a negative lead 1. Everybody agree? Fair enough? All right. And then we said lead 2, that's pretty easy to figure out. There's our R and S wave, that's negative. And then we said, all right, lead 3, that's negative 2. So in this particular case, we have a negative 1, a negative 2, and a negative 3. What does that have to make us think about? So let's just use this for 1 second. So negative 1, right? It's got to be past the perpendicular line. And then 2 and 3 have to be negative. So what does it make us think about? Extreme right axis, right? And in fact, one of the cardinal measurements, the cardinal rules of thumb, if you will, is down, 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 as we refer to it. So leads 1, 2, and 3, down, 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 negative, negative, and negative, make us think about extreme right axis deviation, right? And again, it should prompt, in the context of a wide complex tachycardia, it should prompt us to be thinking about ventricular tachycardia. It doesn't always have to be ventricular tachycardia. It's just that wide complex tachycardias with extreme right axis deviation tend to be more prone to VTach than they do other things. Yes, ma'am?
Could you explain the difference between the R and the S wave?
Yeah, so if you think about sort of the nomenclature naming conventions, right? So we think about the R wave being the first positive deflection after the P wave. Now, unfortunately, this guy doesn't have P waves, right? So it's a little bit of a dealer's choice here to figure out exactly where this starts and where it ends. But I would suggest to you that that's kind of T wave looking, right? So T waves tend to be sort of dome shaped and not generally like mountaintop peaky looking things, although they can be, but more often than not sort of dome shaped. So I would, in my head, say that is a T wave, which means that the first positive deflection here is not a P wave, it's an R wave. There's our R wave, and there's our, and the S wave being the first negative deflection after the R wave. So there's our S wave, right? And then probably the J point is somewhere in this neighborhood. Everybody knows what I'm saying? Everybody knows J point, right?
No.
Okay, so J point is the point in which the final wave of the QRS complex converts back to the isoelectric line, right? So it's essentially, the simple way to think about it is the point in which it stops being a wave and begins to once again become a line.
Maybe draw to the chalkboard.
Yeah, I can.
So we've done 3-lead ECGs up until now.
Yep.
And we're starting 12 leads next week.
Okay. The J point will be very,
I've already started doing them in,
Oh, so half of the class, a quarter of the class.
half the class is done, or yeah, half the class.
Okay.
The other half get intubation, so.
the J point is really relevant in 12 lead EKG because it's the start of the ST segment. So when you go, this guy has injury as evidenced by elevated ST, you'd say the J point is elevated compared to the rest. So just to review real quick, isoelectric line, right? And we usually measure isoelectric line, it's sort of the TP segment, right? So from the end of the T wave to the beginning of the P, that's sort of a good, it's not perfect, but it's sort of a good way to think about where the isoelectric line is. Okay, so naming convention then says that the first positive deflection is the P wave, which signifies depolarization of the atrial muscle, right? Okay, and then there's, if you want to talk about the PR interval, that signifies the time it takes the energy to go from the SA node to the end of the conduction pathway, right? Till it exits the Purkinje fibers and starts depolarizing the ventricular muscle, okay? So then we have a series of other deflections that represent depolarization of the ventricular tissue, right? So a lot of people will have a Q wave, right? And that first negative deflection after the P wave, generally speaking, corresponds to the movement of the energy out to the septum, right? Because there's a little bit so imagine, if you will, this is lead 2, right? So there's a little bit of energy that has to kind of go this way, right, to catch the septum. So it's, in some people, represented as a negative deflection, okay? And then usually what we see then is the large R wave, right? The first positive deflection after the P wave, that's the R wave. And then, so remember that the Purkinje fibers then curl up a little bit and catch the outer walls of the ventricle, so that creates another negative deflection as energy kind of moves up this way a little bit. And that's the, we refer to that as the S wave, right? And then at some point, that wave will then go back to the isoelectric line. So in this case, you can see it right here, right? That, where that sort of crook is, or that angle there, that's the representation of the wave becoming the isoelectric line again. And then eventually, in most people, we'll have the T wave, and the T wave is the repolarization of ventricular tissue. Slower, less abrupt because it happens over more time, and sort of gentle because it's a lot of energy. It's a lot of tissue, but not a ton of energy. Fair enough? Does that answer your question regarding the? So there's the J point right here, right? And then when you look at 12 lead EKG, we're going to examine the ST segment, right? So essentially this segment right here, right? We want to look at that because, again, without getting too far off on a tangent, when I begin to rob all those sodium potassium pumps of energy from blocking blood flow, right? I begin to change repolarization, right? Sodium potassium pumps are designed to move those ions back to a polarized state to prepare for the next depolarization. I always equate that to being like a bouncer. I worked as a bouncer in a bar when I was going through paramedic school, and it was an 18 and over club up in Waterville, and it meant that all night long I would be constantly helping people go from the 21 side back to the 18-year-old side, right? So I thought of myself, not at that point, but I think of myself now as the sodium-potassium pump, right? I need that polarized state to be the case, right? And, but the requirements of the job was that it took time and energy, right? All night long, all I'm doing is moving people back and forth, right? I'm beat. I'm tired of doing this. But I was rewarded with money. They give you money to do this job. So I was happy and I'll keep doing it. So if my boss came to me and said, geez, Dan, we're a little short this week, I'm not going to pay you. What's that going to do to the depolarized state of the bar? You guys go wherever the hell you want. I don't care. I'm done, right? So that depolarized state is really not going to change. And the same thing happens when I begin to rob sodium-potassium pumps of myocardial cells. They just aren't going to repolarize the way they did. Now, remember, it's not a binary state. It's not on or off. The more I rob, the better it works. And so what we're looking for is changes in repolarization, which is why we look at the T-wave polarity, right? If we start changing the vectors of depolarization, we see things like flipped T waves. We see things like elevated or depressed ST segments, because that part of the QRS complex, of the overall QRS complex, represents repolarization of the ventricles. Fair enough? All right. Is everybody feeling better about this? Okay. What questions do you have? I mean, pretty much everything else I have is just sort of like practice. And I'm happy to keep practicing, but I kind of get the vibe that everybody's kind of getting it, so I'm not sure how valuable that is. Again, I'm happy to do more practice if you want, or if we can talk about other things if you want. What say ye?
Could you go over some of the reasons for the active?
Sure, yeah. Let's start with really simple and physiological, right? So a woman gets pregnant, right? So her heart is normally sitting like this. And remember that if you were opening up a chest cavity, you would see that the heart is not in the nice quadrant system in front of you. It's actually pivoted, and it's rotated and pivoted, right? So if you ripped open their chest wall, you'd see the right ventricle right in front of you, right? Okay, so, and remember that we're putting those leads on, so we're seeing sort of energy moving towards that left ventricle. Okay, now, she gets pregnant. The uterus goes from being the size of a hot dog bun to being the size of a basketball, right? And it puts pressure on the diaphragm, which therefore puts pressure on the heart, and it actually makes that heart shift this way. Right? So now that left ventricle is physically moved. It's now up here more than it was down here. Right? How does that change the axis of depolarization when I measure it? It's up here, right? So a lot more of that energy is going this way than it's going that way. Right? It's simply physically moved heart. Right? So that's the reason why there's a great many people out there who have physiologic left axis deviations. Right? It doesn't necessarily have to be electrophysiological. It may actually be physical, right? If you displace the heart. We can also see similar stuff in like tension pneumothorax, in other conditions that actually physically displace the heart. So that would be one of the big reasons. Okay. Now the other reasons, generally speaking, result from changes in the conduction, changes in the direction in which energy moves through the heart. So we'll go back to the chalk talk here. So there's our heart, right? And then again, if we kind of think about it in terms of left ventricle and all that, and then if you figure the SA node is up here and the AV junction's down here, right? And then you have the bundle of His. And then you have the left bundle and the right bundle. And remember that the left bundle has 2, sometimes 3 fascicles. Right? That's the physiologic makeup. Okay, so now let's say that many years ago the guy had an MI and it affected this bundle right here. And in fact, it created an area of scar tissue And we know that dead scar tissue doesn't conduct electrically neutral, right? So now he's got a big sort of a big pothole in the conduction superhighway, right? So now energy goes, remember I'm showing you a two-dimensional model, but it's not two-dimensional, it's three-dimensional. But let's say that, when it's coming down this superhighway, it hits this area and stops, right? But remember, at the time it stops, the energy also goes, I'm going to use a different color, so I'm not really, but it's going this way at the same time, but stops here, right? So now, as Mitch, I think you said before, when I go off the conduction superhighway, or somebody who, I'm sorry, is that the wrong name?
Yes.
Well, who said that?
Mitch, that one's Chris.
Chris, I apologize, Chris. So as Chris astutely pointed out earlier, that when conduction leaves the superhighway, right, the conduction pathway, it then begins to have to go cell to cell. And those myocardial cells have far fewer intercalated discs, they have fewer gap junctions, and therefore conduction is slowed. So it's going loop, doo-doop, doo-doop, doop, right through there to go really slow, but it's going boom down here, right? So the problem is when the energy gets down here, it says, wait a second, all this area right here is not been depolarized yet because it's still waiting for the energy to get around the block. So what does it do? Boom, it's going up that way. Because if I took a bucket of water and threw it, water's going to go in any direction it can, right? Even though it has a general vector, I'm splashing it this way, but if it finds little potholes and things over here, it's going that way too, right? So that's essentially what's going on here. That energy's coming down. If it finds non-depolarized tissue, it's going back up. So when I add all these vectors up, it begins to change. Instead of going this way, when I add them all up, maybe it's going this way, and I have a right axis deviation, for example. Okay, same thing on the other side. Same thing on the other side. If the energy is coming down into that left bundle and is blocked, right? It might go this way to depolarize the area here that hasn't yet been depolarized, but was otherwise is a blocked area. Yes, sir. Oh, yeah. Thank you. There's some other things too. What was I just going to say? I had one in my head. There's some other reasons too. So we talked about scar tissue. We talked about, we can see, like for example, heart tissue can be rendered neutral not just because of scar tissue and damage, but also because of other depolarizations. So if this guy has an ectopic focus right here, and he's firing, and this area is found to be in a absolute refractory period when the energy hits it, then it's going to find a different pathway too. So it might be an electrical block, if you will. It's not really a correct term, but again, if that tissue is neutral because it isn't repolarized yet, a similar condition can occur. Fair enough? Look, it's much more complex than this, and the reason I'm hesitating mostly is because I think, so in anything with cardiology, we build on foundations, right? That once you have a set of knowledge, it's easier to fill the blanks in, right? But if you start skipping ahead and you don't have that foundation yet, sometimes it's much more ethereal and you go, I don't understand why. Which is why we spend so much time on like physiology and electrophysiology, because understanding those basic building blocks, then you go, oh, of course I understand what the other things are happening. And by the way, as I mentioned before, does everybody now understand this value with regard to what you're seeing? So earlier before, I illustrated a QRS complex. So okay, and I said this was lead 2, right? Why is that R wave upright? Because in lead 2, in this particular case, energy is moving towards that energy. Okay, so now let's change it a bit. You run your EKG, and you see that. What do you know? Okay, so at least in part, some of that energy is going away from it, right? So I need more information, but I have a sneaking suspicion that the axis of this person's heart is a little bit different than normal, right? Now, I've got a couple clues that it's not all that abnormal because I have this. What's that? It's a P wave, right? And what does a P wave represent? Yeah, the depolarization of the atrial muscle, not atrial, I mean, theoretically the atrial conduction pathway, but the muscle. And by looking at it, what do I know? But how I've drawn it, what do I know about it? Right. So generally speaking, in this particular case, the energy has moved through the atria along what we would consider to be a normal pathway, right? It's depolarized from top to bottom, okay? And then when it hit the ventricles, something went kablooey, right? The energy started moving in the wrong direction. So this probably isn't a person that has a ventricular rhythm, right? In this particular case, it's not likely that this rhythm originated in the ventricles. Why? Because the atria depolarized normally. Right? So the problem in this person is probably something that has changed the axis of depolarization once it hits the ventricles. Okay? Let's change it a little bit. Whoops. This is like honors axis now, right? So let's not do that. Let's do this. Okay, what do we know? I'm sorry, lead 2. You're right. Thank you very much for asking that question. Because he's right? Because if this was V1, it might be entirely different, right? Or if this was AVR, it might be entirely different. But in this case, it's lead 2. Tell me what we know by looking at that. So it's an inverted P wave. What causes a P wave to be inverted? Okay, it could be ectopic. Yeah, but that's the textbook answer, and it's a correct answer. But I want the understanding answer. So tell me why in a junctional rhythm would the P wave be inverted?
So typically, starting in the SA node, moving downward.
Right.
We would have an upward P wave.
Correct.
So if it's moving the opposite way, so originating from like the AV node area or below the SA node, moving up.
Excellent. Exactly right. Okay, so there's our SA node, our AV junction. In this particular case, let's say that the impulse originated somewhere like here, right? So that at the same time, so we have energy that starts here. It does go down and depolarize the ventricles normally. How do I know that? What's that? Because QRS looks cool. Everything's cool with that, right? It's depolarized that. But this is unusual, and this results from that energy saying, well, I got some open tissue here I can go to, and go in this way.
Why is the impulse starting there? Is that just ectopic?
Okay. It is it's ectopic, but it's ectopic for a reason. It's escape mechanism, right? So the reason that the SA node is the dominant pacemaker is because it has a higher intrinsic firing rate, right? It fires so fast that it becomes the dominant pacemaker, right? Now, the SA node, it's sort of like the AV junction is sort of like the backup quarterback. I'm ready to go, I'm ready to go, I'm ready to go. But look, we got Tom Brady over here, man. He's like, for a football fan, the AV node's like Jimmy Garoppolo, right? I mean, he's ready to go in, he stretches out before the game, everything's cool, right? But we got Brady, right? And we're not going in as long as Brady's working. Brady goes down, guess who's going in, right? So in this particular case, the reason the AV junction doesn't fire is because it's constantly being depolarized by impulses from the SA node. I'm ready, I'm not ready. I'm ready, I'm not ready, right? That's basically what's happening here. But if we shut off the SA node or significantly slow it down, like for example with massive amounts of parasympathetic stimulation, right? All of a sudden, boom, the AV node goes, nothing, really? I'm going in? Oh, okay, I'm going, right? And he goes, right? But remember when he fires from way down here, a lot can be going backwards.
So just trying to show the shortened PR intervals.
Yeah, so I'm glad you noticed that, right? So why is the PR interval shortened? What does the PR interval represent?
Roughly the time distance between the start rate drill
Right, so,
and the start of ventricular contraction.
right, exactly. So basically from the start of the impulse all the way down through exiting off of the conduction pathway into the ventricular muscle, right? So this is shorter. It's a known distance, right? It's the 100-yard dash. We've had 1,000 people run the 100-yard dash and 1,000 coaches with stopwatches and say, well, it's 6 seconds, right? You know, whatever. And in this particular case, we've measured PR intervals from the time of Dr. Einthoven until today, and we've determined that that PR interval is what's a PR interval supposed to be? Point what? 0.12 to 0.20, and again, depending on the reference, it might be 0.1 in your textbooks. But so it's a known distance, right? And we say, look, in all of these runnings, no one has ever run it shorter than 0.12, right? Under normal circumstances, it must take at least 0.12 seconds to get from the start point to the end point, right? But here in this particular case, it's 0.08. Somebody's cheating. Right? It's just it's not possible to make that work. So what we consider in a shortened PR interval is that the impulse was generated at a point lower on the conduction pathway and therefore a shorter distance to the endpoint. So that's a clue, a very important clue for us that this is a junctional origin. The origin of this beat is junctional nature.
Why wouldn't, if the conduction is starting to change, why wouldn't you lose the P wave completely?
Yeah. Okay. Thank you very much. I love that question. Fantastic question. Okay, so here's the thing. The AV junction is a bit of a moving target, if you will. All right, so here's what I liken it to. If I said, anybody here from Boston? Or know Boston? Okay. Where's downtown Boston? Okay. You from Boston?
I lived there for a while.
Where's downtown?
Like over by the garden.
Yeah, by the garden, right? But the point is, he didn't say it's the corner of 8th Street and Market Street, right? He said, it's down by the thing over there. And frankly, if I polled 5 people in this room from Boston where downtown is, I'm probably going to get 5 answers, right? Even if you said, where's downtown Biddeford? Right? You'd probably say, well, it's somewhere down over there, it's around the area, right? So it's the same kind of thing with the junction, right? We want the junction in our head to be a precise point where you go, that's your junction right there, right? But in fact, it's really not. It's an area. And remember that it's not necessarily an organ that you can dissect and pull out and go, well, there's the junction, right? It's thousands of independent little junctional cells all sort of clumped together. So the fact is, and I apologize that it's going to be a little bit hard to illustrate this in a small sense, right? But, well, let me draw it a little bit bigger so you can see. So, there's our heart, right? And our AV junction, I'm sorry, did it backwards. Kind of looks like this, right? It's a big area. Right? And when I say that something is junctional, I might mean that the impulse originated here. But at the same time, I could also say the impulse originated here. And at the same time, I could also say the impulse originated here. Right? I could be standing in front of the TD Garden, and I might say I'm in downtown. I might be in the financial district 5 blocks away and say, yeah, I'm in downtown. Right? I might be on the other side of the North End and say, I'm in downtown, right? But which one's wrong? None of them, right? And that's kind of the same situation here. Now, where this gets a little tricky is each of these impulses will have different characteristics on an EKG because they originate in different places. And remember that all this tissue in here has an intrinsic pause. right? So it's designed to slow that energy down a little bit to allow things to go through. So okay, so if I started up here, I'm still going to get a negative P wave because a lot of that energy is going through there, right? But I'm going to have a little bit longer PR interval because the energy is going to go down through here. It's still going to be shorter than normal, but it's going to be a little bit of a longer PR interval, right? And then it's probably going to depolarize the ventricles normally, okay? If I start the impulse down here, what am I going to see first? Ventricular, right? Why? Because it's really close to the ventricles, right? So in this particular case, I might have something that looks like this. All right, there's my ventricular depolarization. And then I might have, got to go through the pause, and then I get up here, I might even have a retrograde P wave, right, after the depolarization, because it's gone through here, and when it reaches this point, it depolarizes the atria. Now, here's the problem, and cardiologists hate you, so we'll just put that on the table. Sometimes retrograde depolarization is not allowed, right? In some cases, the AV junction will just say, yeah, you're not going back through, right? So it might not have that retrograde P wave. Now, here's the other one. If I start it right dead square in the middle of the junction, pow! I'm going in both directions at the same time. Which one am I going to see first, typically? Ventricular, why? It's it's bigger, but it's a hell of a lot more energy, is the point that I'll make, right? So in this particular case, what I would see would look something like this, right? I would see ventricular and probably not a P wave, but if I could see a P wave, right, if I could somehow block the ventricular function, what I'd see is that P wave would be sort of like right in there. You obviously won't see that, but it happens simultaneously, but because the ventricle takes up so much of the energy, you just don't see that P wave. Which one is ventricular? All of them. I'm sorry, which one is junctional? All of them. But that's the thing that, that's when I said before that axis is more than just determining where's the deviation and what number it is. Understanding that axis and how energy moves through the heart and how it will make the determination of what you're seeing in the QRS complex, that's the value of axis right there. Because when you're going through those junctional rhythms and going, well, is it junctional, is it something else, that's how you're going to understand why P waves are upright, why they're negative, why they're biphasic in some cases, all those sorts of things. What else can I answer for you? What else can we talk about? All right, I feel you're all satisfied then. All right. Thank you very much for your time. And if you have any questions, please, Corey has my contact information. Please feel free to let me know, and we'll go from there.